Sí, le hicimos despertar tempranísimo. Ahí está. Perfect. Well, Ivan, let me introduce you to the rest of the crew here. We are 3 now, besides me.
Okay.
We have Mariel, our previous fellow, Carolina, our current fellow, and,
Okay.
and Sergio from Bolivia, who's doing an observership now. We're all eager to hear your knowledge.
Oh, thanks, guys. That's very kind of you. I can't see you, but I'll trust that you're telling me the truth. Sorry if you see me and I look like I'm...
We cannot see you in pajamas.
Sorry?
Thank you for waking up.
Yeah, I was gonna... No worries. I was gonna say, if you can see me, I look like I'm a hostage because I'm in my bedroom while my kid and my wife are sleeping. So I'm going to, I guess I'll get right to it and I'll start. If ever you guys have any questions, please just interrupt me. No worries whatsoever. And I'll stop at a couple of places as well just to resume what we've talked about so far. So I'm going to talk today about inflammation of the orbit. And I will start by showing you just the kind of plan of the talk. So the goal is to really provide for you guys a practical review of primary, also known as autoimmune inflammation of the orbit. And, hold on. For some reason, my computer... we're going to first go through the presentation of how inflammation of the orbit actually walks into clinic. We'll go over the differential diagnosis, the workup, and really the goal is just to obtain the likely diagnosis and provide the patient the help they need prior to referral to oculoplastics. But in your guys' case, because you're going to be in the field, it's also just a stronger understanding of how to view this complex pathology. So how does it present? Well, primary inflammation of the orbit has 3 anatomic variants. There's dacryoadenitis, or inflammation of the lacrimal gland. There's myositis, or inflammation of the extraocular muscle. And there's fatty inflammation, which is just inflammation of the fatty compartment. And it's important to note that the chronology of inflammation of the orbit can be acute, which usually implies hours to days, or chronic, which is on the order of weeks. Most publications will consider it chronic when it's greater than or equal to 6 weeks in duration. And it's important, and I'm going to talk later on in the talk why that is important. So let's look at dacryoadenitis, or inflammation of the lacrimal gland. Dacryoadenitis presents as edema and pain of the supratemporal orbit, as you see in that picture. And eversion of the lid can sometimes, in certain cases, show inflammation of the palpebral lobe itself, where you see that yellow arrow pointing to the palpebral lobe of the lacrimal gland. And on imaging, what you typically see is diffuse enhancement of the gland with or without enlargement of the gland itself, where you see that red arrow is a typical case. Chronologically, it can be acute, and in that case, it's usually severe. These are the patients that walk into your clinic that have relatively sudden onset of pain, and if you touch their supratemporal orbit, they kind of recoil back in discomfort. But there's definitely also cases of chronic inflammation of the lacrimal gland, and in that case, it's subtle. Often they have few symptoms, and it's really just a mass effect. Typically, those patients will be referred, at least in our healthcare center, by an optometrist or by a GP, or somebody who just says it looks like the eye is displaced to one side, and the patient will walk in not really complaining of very much. Myositis. Myositis is something that presents as pain on activation of the affected extraocular muscle or of its antagonist. And interestingly, there are many publications now that show that the strabismus pattern can be restrictive, paretic, or mixed. So if somebody, for example, has lateral rectus myositis, that individual can have limitation in abduction or adduction on the affected side. And on imaging, yes.
Can we make a comment? Most of the patients that I've seen with myositis have paresis rather than restriction. Is that your experience?
Yes, it definitely is my experience, and I think that what changes it is probably the chronology of presentation. There was 2 studies, one that had about 35 patients out of Moorfields from Jeff Rose, and in that study, it was roughly 20% that had some form of paresis, excuse me, some form of restriction as opposed to paresis. The thought is that maybe the restrictive patients were more so longer lasting myositis that had kind of burnt out. And for that reason, they got some fibrosis within the muscle. But based on the two biggest studies that exist, patients that came in with diagnoses of myositis, some of them did have a paretic pattern.
We have a request.
The yes, absolutely.
If you can slow down a little bit, because of the English, it's not our first language, so a little bit slower would be.
Oh, sure. Do you want me to?
No, we're fine. But
do you want me to go back?
A little bit slower. Yeah.
Okay, sure, no problem. So on imaging, what you'll typically see is enlargement and enhancement of the extraocular muscle. So the muscle that's affected will be more voluminous and will enhance with contrast, but the anterior tendon does not always have to be involved. We know that in thyroid-associated orbitopathy, the anterior tendon should not be involved, but if the anterior tendon is not involved, it doesn't mean that the patient does not have autoimmune or idiopathic myositis. So the tendon being involved is indicative of myositis that isn't thyroid disease, but it is not a very sensitive sign. It's more so a specific sign. When it comes to chronology, again, it can be acute or chronic. And if it's acute, which is the majority of cases, these patients come in with acute and significant pain. But there are some rare cases that have been published also of myositis where patients come in with enhancement of the extraocular muscle, enlargement of the muscle. It's biopsy proven to be idiopathic myositis, for example, and they come in with very little discomfort, although that's rare. Fatty inflammation. Well, really, fatty inflammation of the orbit presents with varying symptoms, and it's all based on the location of where fat is inflamed. Given that fat makes up the vast majority of the orbit, if, for example, the fat of the orbital roof is affected, well, patients will come in usually with ptosis. If it's the fat at the apex of the orbit, well, they can come in with multiple cranial neuropathies. So it all depends on where the fatty compartment is affected. And here's a patient that I had about 7 months ago, and he has fatty inflammation on both sides. It was affecting his orbital roof on the left side, which causes ptosis and severe edema on the orbital roof. On his right side, it was infratemporal and intraconal. He had some proptosis on that side, injection, and you could see his lower fat pad significantly affected. Imaging. Basically, you just see enhancement of the affected orbital fat. So here's that exact same patient. Here's his MRI, and you can see the fat surrounding the superior rectus on the left side that's enhancing, and you can see the infratemporal fat on the right side that's enhancing. How's the speed? Is it okay for you guys?
Are you okay with the speed? Thumbs up here.
Thumbs up. Okay. Okay. Good.
If we can share. Maybe you can see us. I don't know if that's going.
And if ever there's a word because of the English that isn't clear, just please interrupt me. No worries whatsoever.
Go ahead. I'm not sure I can put two cameras here. You can't see us, can you?
I cannot. No. But I saw you at the beginning, Martin.
Yeah. Well, we're seeing you, so don't worry.
Okay. Whatever, good enough. Chronologically, fatty inflammation, again, and I'll talk again why this is important later on, can be acute or chronic. If it's acute, often the patients like this individual who I saw will come in with severe pain and discomfort, but it can be chronic as well. And in that case, it's very subtle. The patients will walk in with sometimes very few symptoms, and it's primarily a mass effect. So again, they'll be referred without much complaints, except that they'll have proptosis. So what about the differential? So I'm going to first list to you guys this differential, and I put it in quotes as the textbook differential, because if you look at large review articles or if you look at textbooks, they'll give you this whole kind of bullet point of different things that can cause inflammation of the orbit. So I'll first list it to you, and then we'll break it down so that it's a little bit more palatable. So the first large aspect of the differential. So patients that come in, like I showed you, that have dacryoadenitis or myositis or fatty inflammation is primary or autoimmune disease. And I break down primary or autoimmune disease into three categories. The first is the big four, and I call them the big four because these four diseases really are by far the most histologically reported pathologies that cause inflammation of the orbit. And those are sarcoidosis, granulomatosis with polyangiitis, also known as GPA or Wegener's disease. There's IgG4, and there's Sjogren. So these guys really make up the bulk of case reports and series and general reviews on the subject. There's also the entire category of other. So that's every other autoimmune disease that exists. There's Crohn's, ulcerative colitis, lupus, rheumatoid arthritis, vasculitis, all these other things that have all been documented to either directly or indirectly cause inflammation of the orbit. And then there's lastly idiopathic. And we'll talk about idiopathic later on. So there's this big rubric of autoimmune primary disease, and it's those three categories. There's also infection. So when somebody comes in looking like, I'll go back, looking like, do you see my cursor?
Yes.
Looking like this patient, you say to yourself, is it any of the large primary autoimmune disease category? Does he have an infection? Is it thyroid? Is it a malignant neoplasm like lymphomas or any of the host of carcinomas that we encounter? Is it a benign lesion like a ruptured cyst or a thrombosed venous malformation? And then there's, of course, the category of exogenous. There's drug reactions, foreign bodies after a trauma, etc. And when it comes to drug reactions, there's a ton of reported cases, but I would say the vast majority are IV bisphosphonates in the context of patients that are going to be receiving chemotherapy. I wrote up one of these cases, but there's like much larger case reports of sudden acute exogenous drug reactions from IV bisphosphonates. And actually, if you go back to this guy, this was IV zoledronic acid, which is a bisphosphonate. He was an individual that needed IV bisphosphonates for some other rare disease. And within 24 hours of getting the drug, he walked into the hospital looking like that. So those are the categories. But this really, when you look at it, is vast and overwhelming. That's a ton of different diseases. It's a giant swath of pathologies across medicine. And unless you're really comfortable with it, it's very, very overwhelming. So how do you really narrow this down? How do you narrow all those categories down? Well, when you think about it, your primary concerns really are which of these diagnoses can be easily missed, and which of these diagnoses can be sight or life-threatening. And if you look back at this differential and you look back at this list, although textbooks will show you all of these categories, the reality is that when you look at thyroid, thyroid really 99% of the time has stereotypical findings. We all know what thyroid-associated orbitopathy looks like. It's very hard not to think of thyroid after doing a thorough exam and getting a CT scan. So, patients that look like the individual that I showed you, or patients that come in with dacryoadenitis acutely, it really does not evoke a diagnosis of thyroid-associated orbitopathy. Same thing with malignant neoplasms. It's hard to miss thinking about a malignant neoplasm after you've examined the patient and got just a basic CT with and without contrast. Exact same thing for benign lesions. Rarely does a cyst or a thrombosed venous malformation not get caught on a basic workup. When it comes to exogenous, it can look like anything, but I always ask my patients about recent drug use, recent drug administration, especially IV bisphosphonates, and I usually ask them about these series of different medications that I have listed here. And almost always it's somebody who comes in and just says, I'm on high blood pressure medication or cholesterol medication, and that's it. And foreign body, I also always ask about a past history of any type of trauma or any type of surgery around the orbit. So when you really look at this from a practical standpoint, when these patients walk into your clinic, what you're really asking yourself is, does the patient have an infection or is it in this autoimmune category? And infections are something that should be feared, and it should be feared with good reason, because infections can be sight or even life-threatening in some cases, and they definitely can look like autoimmune diseases in some cases. The problem is that there's generally a reflexive fear to always thinking about infection in all of these cases, and to never think about primary or autoimmune inflammation. And what I'll typically see, I don't know if it's the case for you guys, but what I'll typically see are patients that are referred to me with refractory infections. So somebody who they just assumed had an infection has been getting kind of drowned with antibiotics. Nothing has been getting better in time, and the full workup and the correct workup hasn't been performed. So that's the typical case that I'll see. So how do you ask yourself, how do you break it down? Is this inflammation or is it an infection? What I do as my first step whenever any of these patients walk into my clinic is I look at any of the 5 signs of infection, and I'll list them for you. Is everything okay speed-wise? Is it clear?
Yeah.
Okay. So the 5 signs are, is there a cutaneous lesion or a point of entry? So did the patient have a bug bite? Is there a cut that's there that could be a source of infection? Does the patient have sinusitis? Is inflammation in the orbit contiguous or adjacent with the sinuses? Is there pus, either on the surface of the eye, which you can see, for example, in cases of very rare documented bacterial infectious dacryoadenitis, or is there pus within the orbit itself, which is obviously a classic sign of an infectious process? Is the patient immunosuppressed, which is always a red flag? So diabetics, chemo, AIDS, you name it. If all of these 5 signs are absent, you have to consider primary inflammation of the orbit. So if a patient walks in with dacryoadenitis or myositis or fatty inflammation, and none of these 5 signs are there, it behooves you to think about inflammation and not just consider infection. So if you look back at this differential, and we have inflammation, infection, thyroid, malignant, benign, exogenous, if you have done a basic workup, ordered routine imaging, in 95+% of cases, thyroid, malignant, benign, and exogenous very quickly go extremely low on the differential. If you've looked for your 5 signs of infection and they're not there, well, you can lower infection on your differential, and you have to start thinking about autoimmune disease. So a key take-home point is that, especially before the patient walks into an orbital surgeon's office, autoimmune disease is typically ignored, and that's where the mistake is made. If you look at this entire category of autoimmune disease, it in itself is quite large. And what you always ask yourself, what I ask myself is, well, can this be narrowed down even further? Can I figure out what's going on here within this category of autoimmune disease? And the answer is yes, you can. And that's by asking yourself if the disease was acute or chronic. Do you guys have any questions so far?
Any questions? No questions. It's
No.
pretty clear. Very
Okay,
clear.
good. Okay, so, pardon?
They would understand it right away.
Okay, great. So acute inflammation. So let's talk about acute inflammation. I'm just going to take a sip of coffee. Well, to know which diseases cause inflammation, what we really need are reliable blood tests and large-scale studies that have been published, where you take patients with consecutive inflammation of the orbit and you biopsy them and you look at the biopsy results. Unfortunately, blood tests are very disappointing when it comes to inflammation of the orbit, and I'll list for you a couple of examples. So as we all know, ANCA testing is abnormal in only at most 50% of isolated cases of Wegener's disease of the orbit. So patient can have Wegener's of the orbit and you get ANCA testing and it comes back completely normal. It is not like systemic Wegener's disease, where that becomes way more specific and way more sensitive as a blood test. ACE testing is abnormal depending on the series in anywhere from 0 to 90% of people with sarcoid of the orbit. So not a very reliable test either. ANA testing, or anti-nuclear antibody testing, is abnormal in only about 60% of patients that have Sjogren's disease. rheumatoid factor can be normal in 25% of patients that have systemic rheumatoid arthritis, and abnormal ANA testing is abnormal in 23% of patients with no autoimmune disease. So in other words, you can have completely normal testing when the patient does have these diseases, and you can have abnormal testing when the patient doesn't have some of these diseases. So blood testing is notoriously disappointing. Yes?
Ivan, can you clarify what ACE means?
Sure. So ACE is angiotensin converting enzyme. An angiotensin converting enzyme is an enzyme that we test for in patients that have sarcoidosis. When you have sarcoid, ACE is typically elevated, but ACE is not necessarily elevated in every case. It depends on how profound the sarcoidosis is, and it depends on where the sarcoid is located. So if somebody has very bad systemic sarcoidosis and it's affecting their lungs and their kidneys, often their ACE testing will be abnormal, but ACE or angiotensin converting enzyme is in some even large series of sarcoidosis that only affects the orbit, or sarcoidosis that affects the orbit as well as other compartments. In some series, it was completely normal in every patient. So ACE is not a good marker for sarcoidosis. We still ask for it, and I'll go over it later, but you can definitely have normal ACE testing even if you have sarcoidosis in your lacrimal gland. Is that clear?
Perfect. Yeah. And
Okay.
GPA is a current way of calling Wegener.
Correct. Yeah, we actually don't call it Wegener's anymore, because Wegener, it ended up being exposed that he was a Nazi sympathizer. so we don't call it Wegener's. We call it GP ptosis with polyangiitis. It's just the new term for Wegener's disease.
Yeah.
So ANCA is an anti-neutrophil cytoplasmic antibody. ACE is angiotensin converting enzyme. ANA is anti-nuclear antibody testing. RF is rheumatoid factor. So those are just acronyms that we use for these tests. So blood tests are disappointing. That's the first point. The second point is that large-scale studies that look at acute inflammation of the orbit do not exist. They simply aren't there. Instead, when it comes to acute inflammation, we have to rely on expert opinion articles and the best case series that are available. And I listed the most important ones that really exist so far. So remember that we're teasing out information here from basically a consensus of experts, or case series that often only focus on one disease process. So for example, somebody will publish, here are 30 cases of biopsy-proven idiopathic inflammation of the lacrimal gland, okay? But that doesn't tell us about what the frequency is of other diseases of the lacrimal gland. Authors will just say like, okay, we're gonna go back into our trove of cases and look at the last 20 cases of sarcoid in the orbit and see how they present. But we don't have studies that say, here are 500 consecutive patients that have inflammation of the orbit. We biopsied all of them, and here are the diagnoses. That would tell us, X percent of the time, patients have idiopathic inflammation, Y percent of the time they have Wegener's disease, et cetera, et cetera. So instead you go on the general feeling from case reports and experts. And what I can basically summarize for you, because I don't want to bore you guys for like 5 hours, is that the overwhelming majority of acute inflammation of the orbit is likely idiopathic. And I say likely because the majority of the cases don't even get biopsied. They just are given anti-inflammatories. Things get better and the patient never comes back again with the problem. So the authors just presume it's idiopathic. Also, we presume it's idiopathic because in these cases, blood tests are always done and the blood tests come back negative. But like I told you, the blood tests aren't very reliable. So we presume.
What would be your guessing number of the percentage of idiopathic? Like 90?
I would say over 90%. And the reason why it's over 90% is because even in the best series that we have that have biopsies, the majority are idiopathic. And you have to remember that those are the cases that get written up. All of the patients that had inflammation that responded to steroids or responded to NSAIDs that got better and never got a biopsy almost never get published. So you just have to presume, which is the vast majority of cases that never get published, that likely it was idiopathic. The blood test came back negative. The patient never had a yes.
Maybe they don't even get to an orbital center. They're treated.
Exactly. So when you read the articles that are consensus papers, this is one of them that's good, by the many facets of dacryoadenitis by Mumberts, who's a well-known guy. He talks about this phenomenon. Other people talk about the phenomenon. The majority probably don't even get referred to someone like us. Those that do get referred to someone like us often don't even get biopsied. In almost all of these cases, the blood tests come back negative. And for that reason, you have to presume that they're idiopathic. And then even the ones that do get finally a biopsy by an oculoplastic surgeon, the vast majority are idiopathic also. So
let me make a summary up to here in Spanish for them, just to make sure that all the points were conveyed. Lo que dice es que hay un montón de casos que no llegan a ningún centro orbitario, que les dieron corticoides y se mejoraron y que no pasan a ser de ninguna serie. Estos son como las series que se ven en los lugares de derivación, son las que en general no anduvieron muy bien. Entonces, hay que probablemente mucho más del 90% sean idiopáticos, anduvieron bien y listo. Y son una muy poquita minoría los que son específicos y los que son sarcoidosis y todos los que vimos antes. Okay, move on.
So, yeah, I will move on. But also what I have to say is that they're likely idiopathic, but the truth is that they could also have been many cases of any of those, except that it responded to steroids or responded to anti-inflammatories. The patient got better. We figured there's no need to biopsy, so we'll just call it idiopathic. So the overwhelming majority are idiopathic, most likely. But what's a very important point is that the big four, sarcoid, granulomatosis with polyangiitis, IgG4, and Sjogren's, almost never present with acute inflammation. These four diseases that everybody puts in their differential diagnosis. Every time I see a patient, the resident will put it as a differential diagnosis when somebody comes in with, 1 day of sudden acute inflammation. And I always tell them that, remember, it is highly unlikely that these four diseases cause acute inflammation. That is a consensus amongst all of these publications, and it's a consensus amongst all published series. If you look at IgG4 disease, you can find one case report out of like the thousands of reported IgG4 disease of the orbit of somebody who actually came in with acute inflammation. Other than that, they're all chronic. Same thing with Wagner's, same thing with sarcoid, same thing with Sjogren's. It is extremely unlikely for somebody with sarcoidosis to walk in with acute inflammation. So big four almost never present with acute inflammation. And lastly, the other inflammatory diseases like Crohn's, colitis, lupus, all of these other things, they can rarely cause inflammation of the orbit, but when they do, it can be acute. So those are important points. If somebody walks in with acute inflammation, you've walked through your differential, you've put infection very, very low on the list, then I sit in front of this patient and I say to myself, well, it's acute, so it's likely idiopathic. It is almost surely not any of the big four, but it could be anything else. So that's an important point.
Perfect.
I'm going to just briefly talk about a misconception. And again, I don't know if this is something that is more of a North American or a Canadian thing, but I often get patients referred to me with acute inflammation, or I often will hear talks or hear somebody who isn't necessarily in oculoplastics. And there's always this notion that viruses, especially mononucleosis or Epstein-Barr virus, is a common cause of acute dacryoadenitis. This is kind of something that you'll see in textbooks, something that maybe was taught to people during residency a while ago. And I just want to briefly discuss it because it's something that I hear often. And it all really stems from this publication, which is Epstein-Barr virus dacryoadenitis, and it was published in American Journal of Ophthalmology in the year 2000. Just wanted to highlight how the literature is sometimes something that needs to be read very, very carefully before coming to a conclusion. So in this series, there was 16 patients with a mean age of 29 years, and 5 of the 16 in the series were considered to have Epstein-Barr virus or mononucleosis dacryoadenitis. But there was absolutely no histology that was documented in any of the cases, and all patients were tested with quote-unquote EBV serology, but they didn't detail if it was the IgM immunoglobulin or the IgG or the nuclear, which is important in terms of the accuracy of the diagnosis. And all patients were observed without any intervention whatsoever. And the authors concluded that without any true viral isolation, the diagnosis is circumstantial. In other words, this was a series that was published of consecutive patients that walked into a clinic with acute dacryoadenitis, and they think 5 of them had Epstein-Barr virus. But this is far from high quality information. And because of this publication, which is cited in every other review that you'll see, there's this notion that if somebody who's 30 years old walks into your clinic with acute dacryoadenitis, you have to think mono. And the truth is that there's very low evidence to prove that mono is a realistic or common cause of dacryoadenitis. So I just wanted to highlight that because I remember having 2 patients recently that were referred to me, and in both of the consultations from 2 different physicians, they wrote mononucleosis ? So just I think a worthy talking point.
Perfect.
Is that something you guys get? Is that a phenomenon, or is that just
No,
kind of a?
it's not. No, it's not like that. But it's
Okay.
It's interesting how to analyze the literature carefully. And
So we talked about acute inflammation, and then we'll talk about chronic inflammation. And chronic inflammation really is a different type of disease process. And then after that, I'll summarize things for you. I'm just going to take another sip of coffee.
go ahead.
So no questions, guys. Everything's clear?
We're fine. Very clear.
Okay. Chronic inflammation. So large publications do exist with histology for chronic inflammation. So you'll get publications that will say, here are our last 268, as you can see over here, lacrimal gland biopsies. But again, remember that this is a significant bias because only patients that fail conservative therapy tend to get biopsied. So there is no series that exists where there is 300 consecutive patients that walk in with inflammation, and before you even try to give them anti-inflammatories, you take a biopsy. So that doesn't exist. So there's a huge bias in the literature to cases that fail conservative therapy. So that's my first comment. My second comment is that large publications also exist with consecutive orbital diagnoses. So they'll say, here's a very, very big publication that was in ophthalmology from the Shields group in Philadelphia, where they looked at almost 1,300 patients with orbital tumors and orbital inflammation, and they said, here were our diagnoses. However, if you look at this publication, there was 133 patients that had inflammation of the orbit, and of those 133 that had inflammation of the orbit, it was roughly 35% that got a biopsy. So these are patients that were given a diagnosis of inflammation of the orbit caused by X, Y, or Z, with the vast majority not even receiving histologic diagnosis. So again, for chronic inflammation, we have larger studies, some with histology, but there are very significant flaws in the literature. I'll summarize it for you. If you look at these 2 studies, as well as a whole bunch of other ones that have been published, roughly 70% of chronic inflammation of the orbit is idiopathic. However, any other autoimmune disease can cause chronic inflammation. So remember that it can be any of the big 4 that I talked about. It can be lupus. It can be rheumatoid arthritis, you name it, it can be idiopathic. Anything can cause chronic inflammation. It just happens to be that the majority of cases are idiopathic. The important point also is that malignant tumors can masquerade as chronic autoimmune disease. So these are patients where if it's chronic in nature, you'll get a series of, here's 300 patients with consecutive biopsies. We presumed some of them were inflammation, and it turns out that some of them were lymphoma, some of them were adenoid cystic carcinoma, some of them were other types of malignant processes. So I'll recap what I've told you guys so far. The first is that primary orbital inflammation can present as dacryoadenitis, myositis, or fatty inflammation. The differential is enormous if you open up a textbook, but it usually ends up being primary inflammation versus an infection. The first step with these patients is to look at the 5 signs of orbital infection, and I'll go over those again later on in the talk. And if they're absent, primary inflammation needs to be considered. If you have isolated the process as being primary inflammation, the next step is to ask yourself, is it acute or chronic? If it's acute, it is most often idiopathic. It is almost never any of the big 4 that I talked about, so sarcoid, Wegener's, IgG4, Sjogren. And if it's chronic, it can be anything under the sun. If somebody comes in with chronic inflammation, these are the patients that will walk in with an enlarged lacrimal gland, for example, and they'll tell you that it's been going on maybe for a year. They don't have very much pain, or they might have a little bit of numbness, for example. That can be anything. So, is this clear?
Very clear.
Okay. So based on this information, how do we work them up? Well, I'm going to give you my workup, and this workup is based on a very good recent publication in JAMA Ophthalmology from the Orbital Society. And in this publication, and I know you're one of the authors, Martin, is bloods. Okay, I know that I told you guys that bloods generally suck, okay, for the lack of a better word. They're disappointing. They often are negative when the patient does have the disease, but we still suggest, and I still order these bloods on every patient that comes in with inflammation, because firstly, they're very low risk. Secondly, if some of these blood tests come back positive, they can be highly indicative of a specific disease process. And thirdly, if ever the patient eventually needs more complicated immunosuppression or gets referred to a rheumatologist or an internist, they almost always want these bloods to be ordered anyways. So just to have your kind of conscience clear, and for the low yield but still certain cases where they do come back positive, I order these bloods on every patient, and I'll walk you through them. The first is a CBC, which is just a basic blood panel, a sedimentation rate, and a C-reactive protein. These are all just basic inflammatory markers. So the CBC includes, platelets, white blood cells, red blood cell count, and typically platelets are elevated when somebody has inflammation, but you also want to look for other things like anemia, etc. Sedimentation rate is a very, very common basic test. C-reactive protein, very basic, and this is just to see how much inflammation is going on in this human's body. The second is liver function tests. Liver function tests are ordered largely because eventually you might want to administer systemic steroids. The next is ACE, like I talked to you about before, and lysozyme, and these are 2 tests that we order for sarcoidosis. There's C-ANCA in particular, which is cytoplasmic anti-neutrophil antibody, and that's for Wegener's disease. There's also ANA, which I talked about. Anti-Rho and anti-La, or LA, are for Sjogren's disease, and RH factor is rheumatoid factor. So these are for a bunch of seropositive autoimmune diseases that can cause inflammation of the orbit. And there's also the basic thyroid blood panel, and even though I know I told you that thyroid almost never causes these types of presentations, or thyroid is very specific, right? These are patients that will either have diffusely enlarged fat compartment of their orbit, or they'll have enlarged, very specific fusiform extraocular muscles. I mean, we all know what thyroid looks like. I still order these tests in every case, and I order them largely because Thyroid is common in general, and because the consensus criteria based on a whole bunch of experts is to order them, just to play it safe. So I'll still order them. And then I wrote IgG4. The truth is that I don't order serologic IgG4 testing, even though IgG4 is elevated IgG4 in your blood is one of the criteria for a diagnosis of IgG4 disease. I don't order it for two reasons. One is that the test is very expensive. And the second reason is that if ever I'm going to even consider IgG4 disease, the patient will almost always get a biopsy anyways. And I need the biopsy to confirm the diagnosis. So I don't usually order IgG4 testing. I always order a PPD, which is the skin test for tuberculosis. And I order it because I might want to administer steroids in the future. And if that's the case, I don't want to reactivate somebody who might have tuberculosis in their lungs. And I also specifically order it for any patients who are like homeless or have been in prison or have a history of HIV or anything that is a little bit suspect. I always order a chest x-ray, and that's as a basic routine workup for sarcoidosis or tuberculosis. And everybody, of course, gets imaging of the orbit with and without contrast. In my center, it's much easier and quicker to get a CT, so I get a CT. If you're more comfortable with an MRI, you can get an MRI, but I generally am more than happy just getting a CT of the orbit with and without contrast. Is the workup clear? The acronyms are clear?
Yes.
Okay, so that's what I do. Now, what about intervention prior to referral? So the patient walks in, I order these tests, and the basic algorithm is the following. If the patient has acute inflammation, so it's been on the order of hours to days, and they're in pain, I give them NSAIDs. I start with nonsteroidal anti-inflammatories, and my typical formula is naproxen or naproxen or naproxen, depending on where you get it, 500 milligrams twice to even 3 times a day for 14 days. That's what I start with. If it's chronic, I do not give any medication, because usually if it's chronic, it's been going on for months. And usually if it's chronic, as I'll talk about later, they're going to need a biopsy anyway. So I don't give any systemic medication for somebody who walks into my clinic that says, you know, I've had some dull ache of my eye, and when I examine them, I can see a clearly enlarged lacrimal gland, or there's an enlarged extraocular muscle, and imaging confirms this. I do not give them steroids or NSAIDs. If there's any doubt, of course, of the 5 signs of infection. So if somebody walks into clinic and they have sinusitis that's just adjacent to where there's fatty inflammation of the orbit, or they are HIV positive, or they have anything else that makes me think of an infection, well, I play it safe, and I'll also treat it as an infection. I'm never going to say to myself, well, I'm just going to give somebody anti-inflammatories even though they might have an infection in this case. So if ever I have a doubt, I still also add standard infection treatment. So if it's preseptal, I'll usually give them oral antibiotics. If it's postseptal, they'll often get IV antibiotics and get hospitalized. I also, and this is more so for people who aren't in oculoplastics, if I were giving this talk to a group of general ophthalmologists, I would say, don't putz around, obtain consultation, and ask somebody who knows what they're doing immediately. What about steroids? So this is worth talking about. It's important to remember that depending on the series, anywhere from 40 to 75% of patients that have acute inflammation of the orbit that is often idiopathic, but it can be of any cause, will have rapid and long-term resolution of their inflammation and of their disease with oral steroids. So that is true. However, unless experienced, I do not suggest giving oral steroids prior to consultation with an oculoplastic surgeon. So I would only suggest giving steroids if you're comfortable assessing orbital diseases. And the reasons are twofold. One is that any pathology, and that includes fungal disease, can improve with steroids. So if you give somebody steroids and they have invasive fungal disease. So it's a diabetic and the inflammation is adjacent to the sinuses and there's a little bit of sinusitis. I myself would never give steroids to these patients because I've seen, particularly when I was in California and there was a large incidence of fungal disease, I've seen on more than one occasion a patient that was thought to have inflammation of the orbit, had inflammation of the sinuses that was adjacent to the orbit, was put on oral steroids, and it was actually invasive fungal disease. And in some cases, the patients died. In some cases, the patients needed exoneration. So because you can miss a fungal disease if you're not experienced looking at the orbit, I personally would not suggest administering oral steroids. Another reason why is that just because somebody improves with steroids, it doesn't mean that they necessarily have idiopathic inflammation. Anything gets better on steroids. There's numerous publications of in a whole host of infections getting better with steroids. We've even published fungal disease that gets better for 2 or 3 days on steroids before it gets much, much worse. There are cancers that improve with steroids. So everything gets better with steroids. It's not specific. The second reason is that although it's controversial, steroids can actually yield false negative biopsy results in cases of lymphocytic lesions. So there are cases, although it's a controversial subject, of patients that have had lymphoma. You give them oral steroids thinking that it's inflammation, and the lymphoma melts away. And you then go in and do a biopsy, the biopsy comes back negative, but the steroids then get stopped and the lymphoma comes back. They then eventually get a biopsy and it's confirmed to be lymphoma. So it's controversial. There are some people who don't believe that steroids actually decrease your biopsy yield for lymphoma. But despite that, because of the controversy, especially if you're not in oculoplastics, I would not say to a comprehensive ophthalmologist to give steroids. So my general approach is if I get called by somebody who's a comprehensive ophthalmologist or who isn't comfortable with inflammation of the orbit, and they say, hey, I have this patient who has a relatively rapid onset of pain in their orbit, and it looks like it's inflammation of the lacrimal gland, I would say, start with NSAIDs, start with naproxen, and send the patient to me. That's my general approach. Is this part clear?
Yes. So this is
okay.
Kind of the recommendations for the general ophthalmologist.
Correct. And even for me, if I have a patient where I have any doubt regarding an infectious process, I will never start steroids. I still, like I said back here, when it comes to my patients, if it's acute and they're in pain, I start with NSAIDs, and I'll explain why that is again later on. But I start with NSAIDs. I do not start with steroids. If it's chronic, I don't give anything. And if there's any doubt on the 5 signs of infection, I also treat it as an infection. And if I see somebody who might have a fungal disease, so if I see sinusitis and inflammation of the orbit that's just adjacent to where there is sinusitis, I will not give steroids. I will definitely start with NSAIDs, and I will, in those cases, even consider a biopsy. So I start with NSAIDs, and I act based on how they respond to the NSAIDs. And we'll go to the next step. I'll show you what I mean. So intervention once they get to oculoplastics. So like I said, if it's chronic, if somebody walks into my clinic now and it's chronic, it can be anything under the sun. So I biopsy. So if somebody comes in with an enlarged lacrimal gland or a long-standing, large-looking infiltration within orbital fat, I will biopsy them. The only reason why I don't biopsy these patients is if it's extremely high risk or it's a morbid location. So if somebody comes in and it's at the apex of the orbit and I'm afraid that I'm going to blind them, then in those cases, I will consider an anti-inflammatory trial. If it's acute, my logic is that if it's acute and I know that infection is highly unlikely, well, it's most likely idiopathic. So what I do is I start them on NSAIDs. So I start them on naproxen 500 BID for 2 weeks, and I see how they respond. If in my patients the NSAIDs fail, then I'm left with a question. I ask myself always, do I then try prednisone, or do I go in and biopsy the lesion and debulk and add intralesional steroids? Okay, so if a patient I give them NSAIDs, it isn't getting better. I see them back in a week or 2 weeks, and I say to myself, shit, this is getting worse, or it looks about the same. Then I ask prednisone versus going in and operating on the patient. And what I can tell you is that in general, if the disease location is easily accessible, so it's extraconal orbital fat, or it's the lacrimal gland, my preference now is to biopsy, take a large chunk of it, and to inject steroids. And I'll explain to you why that is. If, however, it's an extraocular muscle, or it's the orbital apex and it's acute, I will go to prednisone. Okay? Is this clear?
Yes.
Hello? Okay, cool. All right. So there's good evidence from recent studies that going to debulk, so take a large biopsy and inject steroids at the time of the biopsy, is a very reasonable first-line approach. And here are 2 important studies, and I'll talk specifically about this one that was published in Ophthalmology. So surgical debulking for idiopathic dacryoadenitis. This was a big case series that was out of the Mayo Clinic and out of also a center in Europe. And it was published in 2014 in Ophthalmology. This was a series that had 46 patients with 7 years of follow-up. And every patient had biopsy-proven acute idiopathic dacryoadenitis. And all of these, actually not all of them, the vast majority were refractory to systemic medications. So these were patients who were sent to the Mayo Clinic or sent to a couple of other centers from other ophthalmologists who had taken a small biopsy of the lacrimal gland. It was idiopathic. There was no evidence of any specific disease. The blood tests were negative, and they gave these patients systemic steroids, or in some cases, medications that were even more powerful after systemic steroids had failed. So there were some patients that were on rituximab or a whole bunch of other immunomodulators, and they still weren't getting better. They still had inflammation of the lacrimal gland that either recurred or just wasn't improving at all. So they were then sent to these centers. And what they did is they took the patient back to the OR. They did a large debulking of the gland. So they took a large chunk of the lacrimal gland, and they also injected intralesional steroids. So they took Kenalog and they literally injected into the lacrimal gland in 56% of these cases steroids. And it turns out that these cases had in 80% of the time complete and permanent resolution of their inflammation with no recurrence at 7-year follow-up. Okay, so these patients at 7 years in 80% of the cases did not require any oral steroids, did not require any oral anti-inflammatories. The disease was just treated. Failure, so the 20% that failed, was correlated with a previous use of steroids. And that's another reason why I prefer not to give steroids if a patient has failed naproxen. So if a patient fails naproxen, I tend not to want to give steroids if I can do a biopsy, because if I then subsequently need to do a biopsy and inject steroids, there's a greater chance that they will fail, okay? And one comment that's important is that 40% of patients had dry eye after surgery, but of those patients that actually had dry eye screening before and after the biopsy, nobody developed worsening of dry eye. So there's no evidence that taking a big chunk of the lacrimal gland and injecting steroids causes worse dry eye. Okay, so it's a low risk procedure that yielded extremely impressive results. So that's my preference. So in other words, if a patient fails anti-inflammatories and they have inflammation in a location that I can easily get to, like extraconal fat or like the lacrimal gland, well, I will take a big chunk of it, I'll inject steroids, and I'll wait and see. If the inflammation is in a muscle or it's at the apex, I'll go on just systemic prednisone. So an important point and an important study. So was that clear? I know that was a detailed look at that one study.
Clear. Let me ask you a question.
Okay.
Why
Yeah, absolutely.
and not other NSAIDs?
So all 3 are equally good. So you can go with ibuprofen, indomethacin, or naproxen. I tend to give naproxen because I actually had one patient, and I guess always one patient reminds you of something, who I gave indomethacin to. and she developed extremely severe headaches. And I ended up asking rheumatology for their opinion, and the rheumatologist told me that they would not suggest indomethacin because indomethacin is equally efficacious to naproxen when it comes to inflammation elsewhere in the body. But indomethacin can be associated, especially in younger patients, with severe migraine headaches. There's just kind of anecdotal reports of it. And in this one patient that I had, I switched her from indomethacin to naproxen, and like literally within 24 hours, the headaches went away. So there's nothing wrong with indomethacin. You can give it, but because I had one case that kind of stuck in my mind, and naproxen works just as well, I go with naproxen.
Okay.
I tend not to prescribe ibuprofen, even though ibuprofen also works just as well. So ibuprofen is Advil or Motrin, just because it's available over the counter. And because of that, I always am afraid that the patient, which I've seen happen, goes to the pharmacy himself after I've prescribed it and decides to start, chugging it like it's candy, and doesn't take it as I had prescribed. So I kind of want to restrict them to taking the medication exactly as I ask. So that's the reason why I go with naproxen. But I know that you can, there are some people also who will treat it like scleritis, where you'll try naproxen. If naproxen doesn't work for a week, you then try switching them to indomethacin. And if that doesn't work, you then say, okay, I can even try ibuprofen, or you can just try oral prednisone or going for a biopsy. So it's the naproxen is just my preference for those reasons, but it's definitely not a hard line recommendation. It's just, this is what I do, and I feel comfortable with it. So here's a real case, and it's a nice summary of everything that I've sort of talked to you guys about. So this was an actual patient of mine. She's an otherwise healthy 28-year-old female who was taking no new medication, had no relevant history, that came into the clinic with 3 days of sudden pain and inflammation of her left upper eyelid. And you can see it here where my yellow arrow is. She also got a CT scan that was ordered. Excuse me, I rephrased this. I didn't explain this properly. This is actually a patient that was seen by an outside ophthalmologist with 3 days of sudden left upper eyelid pain and swelling. So it's important to remember that it was an outside ophthalmologist. And she had scanning that was done in an outside hospital. And here's her scan from the outside hospital, which shows diffuse enhancement and enlargement of the lacrimal gland. And there's also, whoops, I'm not sure why my computer's glitching here. Okay, there's also, as you can see, enhancement of her temporalis, of her temporal fossa outside of the orbit, which is something that you can definitely see in cases of inflammation of the orbit. So she has diffuse enhancement and enlargement of her lacrimal gland and enhancement of extraorbital soft tissue. So what I'm wondering to myself with these types of patients is, what's the likely diagnosis and what should you do prior to referral? So here's our differential diagnosis. Remember, this is that huge list that is overwhelming. And remember, this is I'll go back, this is a otherwise healthy 28-year-old woman with 3 days of left upper eyelid pain and inflammation. Nothing about this, right, makes you think thyroid. If you look at her scan and you look at her history, I mean, it is so extremely unlikely this is a malignant cancer. Same thing with a benign lesion. It does not look like a ruptured cyst. It doesn't look like a thrombosed venous malformation. This was, remember, diffused enhancement and enlargement of the lacrimal gland. And again, she had no history of drug reaction, of a drug administration or any type of foreign body. So like all of these cases, well, not like all, but like the vast majority of these cases, it comes down to, does this patient have autoimmune disease or does she have an infection? So we look at her. If you don't have a lot of experience in this, you can look at this patient, especially if you're in comprehensive ophthalmology, and you can easily think, well, this is an infection, all right? So the question is, how do we break it down? How do we ask ourselves, is this an autoimmune process or is this an infection? Remember step 1, which is to look at the 5 signs of infection. The first thing, is there any skin lesion or entry point? Definitely not. There was no cut, there was no bug bite, there was nothing. The second is, does she have sinusitis? I mean, look at her scan. Her sinuses are completely clear. There's definitely no sinusitis. Was there inflammation contiguous with the sinuses? Definitely not. Her inflammation is in her supratemporal orbit, and it's very distinct from the sinus space. Is there any pus? She had absolutely no pus on the ocular surface. She had absolutely no fluid collection on her scan. And was she immunosuppressed? Definitely not. She was not HIV positive. She was not an IV drug user. She was not immunosuppressed. So this is almost surely primary inflammation or autoimmune inflammation. The next question, now that we think it is autoimmune inflammation, remember the next step, is it acute or chronic? Well, it was 3 days of sudden pain. So this is acute, which means that if we look back at our differential diagnosis, very unlikely to be thyroid, extremely unlikely for a malignant cancer, for a carcinoma, for example, or for an aggressive lymphoma to cause diffuse enlargement of the gland with a sudden 3-day onset. Benign lesions, I mean, 1 in a million. And exogenous, highly unlikely given her history. We looked at our 5 signs of infection. So infection is now really highly unlikely. And we're looking at autoimmune disease. But because it is acute, remember I said that because it is acute, it's very unlikely to be sarcoidosis, GPA, IgG4, or Sjogren's. Instead, it's most likely to be idiopathic or any other autoimmune process. But this physician wasn't 100% comfortable with these types of disease processes and didn't get to hear this talk. And despite what we know, like I told you, the classic mistake of only thinking about infection was done. So instead of getting the proper autoimmune workup, and instead of being put on anti-inflammatories, this patient had a CBC, so a basic blood panel ordered, and she was put on systemic antibiotics. She did not get better with oral antibiotics, and she was even hospitalized with IV antibiotics. It didn't get any better. There was very, very subtle improvement at best. And because of that, she was transferred to our hospital with a diagnosis of refractory cellulitis, okay? Mm-hmm. So when I saw her in clinic, I thought to myself that this is likely acute autoimmune dacryoadenitis. And for that reason, what I did is I added a full workup. So that full workup that I talked to you about, I added the full blood workup, a PPD, a chest x-ray. She already had a CT scan. I stopped her antibiotics because she was already getting drowned on systemic antibiotics that were not improving anything. So I saw absolutely no benefit to continuing it. And I put her on oral naproxen. Here's how she looked prior to the start of naproxen, and here's how she looked 1 week after naproxen. So she definitely improved clinically, and she had near complete resolution within 3 days of her inflammation. And because she had near complete resolution, I continued her on the naproxen for a total of 3 weeks. Now, as a little side note, there really is no good study that looks at the effectiveness of naproxen for inflammation of the orbit. The only study that looked at it a little bit was a study from Moorfields where they looked at myositis, and the results were reasonable. It was about a 50% improvement rate, which was the same as prednisone. And for that reason, they thought that in their conclusion that starting a patient on naproxen was reasonable. The truth is that the majority of publications just start with prednisone. I explained to you why I prefer starting with NSAIDs, but I can't give you a good statistic on how many patients improve with NSAIDs. We know that when it comes to prednisone, anywhere from 45 to 75% of patients will improve. We have no idea what the answer is for NSAIDs. So I start them on NSAIDs and I keep my fingers crossed. She was stable for the last 5 months. I saw her recently in clinic and she looked fantastic. And what's interesting in her case is that the workup was actually positive for rheumatoid arthritis. She had a positive rheumatoid factor. She had very elevated inflammatory markers. I actually referred her to rheumatology, and she was officially diagnosed in rheumatology with acute dacryoadenitis, likely secondary to rheumatoid arthritis. So she was one of those rare cases that was actually likely caused by a specific autoimmune disease, but it could have easily have been idiopathic. So here are the take-home points. The diagnosis of primary orbital inflammation can be intimidating because of a very vast differential. Typically, primary inflammation is confused with infection. The best way to avoid getting confused is to do step one, which is to ensure that infection is unlikely. So look at those 5 signs of infection. And then step two, which is to break down the disease as acute or chronic. If it's acute, it's most often idiopathic, and it's almost never the big 4. If it's chronic, it can be anything. In my opinion, the best way to help patients, either prior to referral or even in my clinic, is to start with the full workup. So all those lab tests that I told you about, a PPD, chest x-ray, and a CT. If it's acute, I start them on NSAIDs. If it's chronic, I give them absolutely nothing, and I just immediately go for biopsy. And my general algorithm is that unless somebody is experienced with the orbit, I do not give oral steroids. And if you have any doubt regarding infection, you treat it as cellulitis and you obtain a rapid consultation. Those are my references. That's it. You guys have any questions?
Round of applause here.
Thanks. Thank you.
Let me see if we can share our camera and say thank you very much for. Can you see us or not?
Yeah, I can see you guys clearly. Can you see me?
Yes, yes.
Okay.
So thank you very much for your waking up so early. It was
No
as
problem.
clear as when I heard it in Montreal, and I was sure they would enjoy it because it's only when you learn something very well you can explain it so clearly. So thank you.
Well, thank you guys. And if you have any questions, please feel free to ask. Usually there's a lot of confusion also about IgG4 disease, which is something that is often confusing from the literature. It's a big topic. So feel free to ask questions. If not, enjoy your day.
Thank you. Okay. Go have breakfast. You deserve it.
Okay, thanks. Thanks a lot, Martin, for the invite. I appreciate it.
Bro, thanks for waking up. Ciao.
Ciao.
Mm-hmm.